So I would like to declare no financial interest. So as we already know that PRK Haze is a dreaded complication seen post PRK, and despite there have being many advancements, in spite of using MMC, there is still a 3.2% incidence rate. So that brought us to the question, why is there haze despite using MMC? And we scoured through the literature and we found that TNF alpha and IL-11 are the two most important biomarkers that are implicated in post-PRK haze. So that brought us to these three important research questions. If we have methods to measure inflammatory markers, are there any surrogate markers that can reflect inflammation, and are there any drugs that are available to target these inflammatory biomarkers? So we came up with a proprietary tool, the Biome Pathfinder kit, which measures about 8 biomarkers. So the tears are measured with the Schirmer strips and are eluted, and we place it in this cartridge which has about 32 wells, and it takes about 90 minutes for the analysis to be done, and we come up with a report that is seen like so. So this has the bottommost part, it tells us the AI-driven map, which gives us, which tells us what percentage of patients are dry eye control, or if the patient has any subclinical inflammation. It is like any other CBC report, and the reports are received in 90 minutes. So we did the methodology. We did our study under the two types. So first one was the observational study, where 50 patients undergoing PRK were enrolled, whose preoperative tears were collected, and amongst those 18 patients who had haze were identified, and those patients' inflammatory biomarkers were analyzed using the kit. And in those patients, we found out that there were higher levels of TNF alpha, IL-6, MMP9, and IL-17. So we found out that in those patients who had lower amount of TNF alpha, it correlated with minimal keratocyte activation on confocal, as opposed to a combinatory biomarker reports, that is higher levels of TNF, MMP, IL-1 beta, and IL-17 had higher keratocyte activation. That correlated with increased myofibroblast activation on confocal. Even clinically, it correlated with higher amount of haze formation in those who had a higher amount of combinatory inflammatory markers. So that brought us to the second question, if it is possible to reduce the incidence of haze with targeted pre-treatment. In this second type, the interventional study, what we did was we enrolled 1,050 patients with similar refractive error. In those patients who had higher levels of inflammation, that is about 355 patients who had, they were randomized into two groups, that is group 1 and group 2. Group 1 received a non-targeted treatment and group 2 received a targeted treatment, and they underwent PRK after 1 month. And the incidence of post-op haze was measured by using Fante's grading, and it was recorded 3 months later and was correlated with the pre-op tear biomarkers. So we found that those patients with a higher level of IL-6, TNF alpha, IL-1 beta, and IL-17, they responded well to procedural therapy and sodium hyaluronate with Trehalose combination. And in our results, we found that in group 1, that is those who received a non-targeted treatment, had lesser amount of haze as compared to group 2, which received targeted treatment, and in those patients we found that there was a reduced amount of haze. So what happens if there is no biomarker kit? How do we do, are there any surrogate markers that serve as indicators of inflammation in our day-to-day clinic? So we found that these surrogate markers like meibomian gland loss, lesser TBAT, higher OSDI, contact lens intolerance, and irregular epithelium were the 5 surrogate markers that can be used as inflammation. And there's already a pre-existing literature that says that if more than 2 of these criteria, that's inclusive of OSDI, if it's increased, it correlates well with higher TNF alpha and IL-17. And if more than 3 criteria are present, it correlates with TNF alpha, IL-6, and IL-17. And if more than 4 criteria are met, then TNF alpha, IL-6, and IL-17, MMP9 are all increased. So we have bridged the gap between the tear inflammatory biomarkers, if it is increased, and how we can bring it to the clinics on a day-to-day basis. So to sum it up, if there is the basal inflammatory threshold is higher, and we perform a cross-linking or PRK at that point, we come across suboptimal results in the form of corneal scarring, poor nerve regeneration, and irregular epithelial healing. as opposed to if we treat them preoperatively with a targeted treatment, then we perform a refractive surgery, then the outcomes are much better. So in conclusion, TNF-alpha is an important biomarker for predicting Haze, and targeted biomarker therapy, it effectively lowers the risk of Haze and scarring. But until we have biomarker kits, surrogate markers are useful, and that pre-treatment will help us to reduce the level of biomarkers before we proceed with any surgery.